I'm going to start tonight with first to say that I have no relevant financial relationships with anything I'm going to be discussing tonight. I want to start with two slides that I showed the first week when we talked about high blood pressure. Since the treatment of high blood pressure and the treatment of high blood cholesterol are very much a pair of tasks that we do in order to prevent heart disease and stroke. And as I mentioned that first week, we've in the United States, we've been doing quite a good job. Things have changed just in the last year or so because of the COVID pandemic. But overall, unrelated to COVID, the death rate from cardiovascular disease, and when I say cardiovascular disease, I refer to both heart disease and stroke, has gone down dramatically, first from 1980 to 2000, and then again from 2000 to 2020. The death rate has gone down quite substantially through each of those decades. And when we analyze why, what we find out is that about half comes from what happens in the hospital, and one might say also in the EMT process, in the community, in the emergency department, and in the hospital and the intensive care units, the CCUs, and now we have neurointensive care units. And those innovations and interventions over the last 20 to 40 years have really totally changed the way we manage both acute heart disease and acute stroke, and they've been very, very effective. And so when you hear that some of the risk factors for having an acute heart problem or an acute stroke problem, that's why that we teach about that, to make sure that you call 911 and get care for that immediately. More in the outpatient side, more in the primary care environment, what we do is we primarily treat risk factors. And we do that with lifestyle and with medications. And when we analyze what's had the most impact, what we see is that it's come from a combination of treatment of blood pressure, treatment of high blood cholesterol, and smoking cessation. And today, I'm going to talk about high blood cholesterol. I also showed this slide, which really is a focus a lot of our thinking when we talk to a patient and when we think ourselves about clinical decisions. And this is true for any decision in medicine, that is to understand that there's benefit and there's harm. And often in clinical medicine, we hear more about the potential benefits of an intervention, whether a new drug or a surgery. And often we don't hear as much about the potential harms. And it's really up to all of us, if we're really on our game, to spend equal amounts of time on both the benefits and the harms. And of course, when we think about modern day medicine, we also think about costs and what we call value. Are we getting our money's worth for the intervention that we're proposing? Is it worth it? We also, in the context of risk reduction, often you will hear about an intervention, and it'll say something like, this new medication lowers the risk of something by 50%. And that's really important. That's how studies get done. That's how medications get approved by the FDA. But when you as a patient want to decide whether you should take the medication, what you also have to ask is a second question, which is 50% of what? That is to say, if your risk of something happening is really, really, really low, and you lower it by a half, you haven't done much good. On the other hand, if your risk of something is high, and the risk of almost everything increases as you age, and certainly risk factors are additive, or in many cases multiplicative, that is, they increase together your risk, and I'll show some examples of that as we go through this. But if your risk is higher, then if we can lower it by half, that's really important. And so that kind of understanding of how effective is the intervention in terms of the relative risk reduction, and that's what always makes the headlines. New drug reduces something by 15%, 75%, but then you have to ask, am I really at risk for that, and does it matter? And what's my native risk? What's my personal risk of getting that illness? Because if I'm reducing a very low risk, it doesn't matter, my risk is still very low. And I'll show some examples of that throughout the night. Okay, tonight we're going to talk about cholesterol. And just I want to start with some definitions, and just so very simple definitions, and one arithmetic equation. And we talk about cholesterol, and mostly we talk about the total cholesterol. This is measured in the blood in a laboratory. These days, it can be done either fasting or non-fasting. We used to think it had to be done fasting, but for most people, it can be done non-fasting as well. And most laboratories now accept a non-fasting specimen. I'll explain why in just a moment. So the total cholesterol, as you'll see at the bottom of the slide, is really just the arithmetic sum of the three other factors, the LDL cholesterol, the HDL cholesterol, and the triglycerides. Now, low-density lipoprotein is the LDL, and that's the low-density, this should be LDL here, low-density cholesterol, a low-density lipoprotein. And I like to say to patients, L stands for lousy. That's not really what it stands for. It stands for low. But the way you remember this, which is the bad one, is the LDL is the bad one, L for lousy. The high-density lipoprotein is a smaller particle, and it confers protection. And so individuals who have a very high LDL, but also have a very high HDL, have lower risk than if the LDL is very high and the HDL is normal or low. So if you have a very low HDL, that confers additional risk of having heart attack or stroke. The challenge with HDL is that we don't have that many medications that increase the HDL, and I'll come back to that. And so we focus a lot of our clinical work on the LDL, the bad cholesterol. The fourth part of the equation are the blood triglycerides. These can be also measured in the blood. The proteins that carry triglycerides are only 20% cholesterol. And so when we do our arithmetic, we divide the blood cholesterol by 5. Now, you don't have to remember this equation because your laboratory results will give you all of these factors, and it's quite straightforward. But it's important to know their relationship. And sometimes people get confused because the total cholesterol might be high. And that can be a little misleading because you can have a high total cholesterol, right, for any one of 3 reasons and many combinations beyond those 3 reasons. That is to say, the total cholesterol could be high because your LDL cholesterol is high, and that would be bad. In that case, the total cholesterol would reflect high LDL, and that would increase your risk of coronary heart disease and stroke. On the other hand, if your HDL is very high, same equation, that will make your total cholesterol high also. And so the total cholesterol may be quite misleading. The high HDL, sometimes you'll see that in individuals where the HDL is very high and the total cholesterol is high, and people get worried, but in fact, they're maybe quite protective. And finally, the triglycerides are a little bit more complicated. When they're very, very high, people are at risk of other illnesses, particularly pancreatic illnesses. Pancreatitis is the most common one. And there are several genetic disorders which cause high blood triglycerides. And those are a different thing, but it's worth noting that people with very high triglycerides from the genetic disorders don't die prematurely of heart disease or stroke. So in general, we don't think of triglyceride as a really big risk factor for heart disease. It does contribute a little bit beyond the impact of the LDL and the HDL, but it's muted compared to the other 2. And for the most part, we don't treat a high triglyceride in and of itself to prevent heart disease or stroke. Again, if your triglycerides are very high, typically over 500 or 1,000, then we do treat it to prevent pancreatitis, but it doesn't add much benefit to the treatment, to the prevention of heart attacks and strokes. So in summary, we have several factors. The laboratory will present you with all of those. The one that we care most about is the LDL cholesterol. Now, it was popular several years ago to create ratios. Obviously, you can divide any two of these numbers into each other. So the total cholesterol divided by the HDL, or the LDL and HDL, can all be made into ratios. But it's turned out those aren't all that important. They don't add very much additional information over and above the individual LDL and HDL themselves. As I mentioned, the total cholesterol means different things. And if you have a little variation in the measurement of any of these, the ratio will multiply that error and just give you false information. So we pretty much don't worry too much about the total, understanding this relationship. The triglyceride we do look at, but in a different context. And we spend most of our time thinking about the LDL cholesterol and the HDL cholesterol. And I'll show you how we do that in clinical practice in a minute. I did mention you can do your measurements now non-fasting, that is not fasting. We used to think you had to do them fasting because the triglyceride, especially in some people, can be elevated after a meal. It turns out that although that's true in some occasional individuals, it mostly isn't true. And since we're dividing the triglycerides by 5, it doesn't have very much impact on the other fraction. So these days we measure if it's more convenient, if your appointment's in the afternoon and it's more convenient to get the blood test then, that's fine. If you want to come back on an empty stomach next week and do it in the best ideal circumstance, then fasting is also fine. All right, let's just think of a situation. So this is a 60-year-old person. The LDL measured was 140. And again, this is how we often talk about these cases. We don't mention the other fractions because for all the reasons I just mentioned. Mostly we focus on the LDL cholesterol as our treatment goal. So just like with blood pressure, where we focus mostly on the upper number, the systolic blood pressure, pay attention to the lower number because sometimes that can be important too, but systolic most important. Here too, all the numbers have some value, but the LDL is really where the action is. Now, this person who we're thinking about doesn't have high blood pressure nor diabetes and has never had any evidence of heart disease or stroke. They follow a diet and exercise to lower their cholesterol as best they can. I will talk more about that in a minute. And the question in the office, and again, this is something we want you to participate in as a patient, is what is our next best step? And some of the choices here are to think more about the benefit and risk before we make any decisions. Secondly, to realize that we have enough information so we can begin a statin, in this case, atorvastatin at a lowest dose. Or maybe we should begin atorvastatin at a higher dose. We can begin aspirin at 81 milligrams, that's a baby aspirin, or we can begin fish oil tablets. And I'll show you the correct answer as we go through the talk, but these are the kind of things that we would be thinking about in the office, and think about what you would like to happen if you were the patient. Now, what's amazing about the prevention of heart disease with medications is that when the statin drugs came out, we had in the decades before that, approximately 20 years of medications that were very ineffective. They barely lowered the blood cholesterol, they had a lot of side effects, and there was very little evidence that they prevented heart attacks or strokes. And if they did, it was by a little amount, and it didn't lead to a benefit on life expectancy, or what we call mortality. But then the statins came out, and these are some of the early statin trials. There are now about 24 or more of these. And the design of all of them was the same. It was one of the statins compared to a placebo in usually a large group of patients. I'll give you more detail on one of the examples in a minute. A large group of patients followed for 5 years, looking at how many of the patients in both groups developed a heart attack that was not the cause of their death, a stroke that was not the cause of their death, a heart attack that was the cause of their death, and a stroke that was the cause of their death. And that way you can look at what we call events, or you can look at mortality. And this is an example. These early studies just looked at events, and this is heart disease, but the data for strokes are very, very similar. And I think you can see across these studies, these initial studies, that really changed the way we think about this, as well as the many, the 24 studies that followed, is that when a group of patients take, or an individual patient takes a statin compared to a placebo, that the risk of developing a heart attack in the next 5 years is reduced by a quarter or a third. So that's the lingo we use a lot, that if you take a statin, you can lower the risk of a heart attack by a quarter or a third. Now, this is where that original seesaw slide comes into play. And so just to reiterate that, if I tell you that this medicine lowers your risk of a heart attack or stroke by a quarter of a third, that's correct. And we have a lot of evidence to support that. But then you should be then asking, what's my risk? A quarter of a third of what? Because if I'm a 30-year-old person or a 40-year-old person, and my risk is quite low because young people don't get heart attacks and strokes very often, then if I lower that by a quarter of a third, I haven't done very much. However, if you're older, like our patient in the case, 68 years old, then your risk, because it's age dependent, it goes up much more. Lowering that by a quarter and a third becomes much more important. And you can see these initial studies were done with some of the older statins, but the newer statins have a similar impact, in many cases, even better impact. Now, this is one of those older studies, but it makes a very interesting additional point. This study had 20,000 patients in it, 10,000 in both the experimental arm with the statin and an equal number in the placebo. And overall, if you just looked at the whole study, just statin versus placebo, the net result is shown here with the green diamond, which shows, so this is, if there was no difference, it would be on the solid line. Rather, now it's moved over to the left, and that shows that statins were better than placebo. And this was a 24% reduction, similar to what the other studies had shown. And so this was really reinforcing. It wasn't brand new information at the time, but it was consistent with the other studies. But this was one of the bigger, first really big studies, 20,000 people, 20,000 subjects. And so it allowed us to look at the patients based upon what their starting LDL cholesterol was. That is to say, in patients whose LDL was over 130, the intervention worked. And so you see the square lines up with the triangle, and it's exactly the same. There was, again, about a 25% reduction if your LDL cholesterol was over 130. If your LDL was between 100 and 130, the intervention also worked. So you see, it's all about the same. The thing that was most interesting about this study, and it's been shown in the study since, is that if your LDL was, quote, normal, what we considered normal at that time, which was under 100, the medication still worked. So that is to say, we think, for the most part, and most of the studies still suggest that the cholesterol-lowering medications work by lowering the LDL cholesterol. But here, something else is happening also, because although we're lowering the LDL cholesterol, we're lowering it in people whose LDL at the beginning wasn't that high. In fact, was what we at the time considered normal. But it still worked. The dot is still on the line with all the others. So this got us thinking, well, maybe we shouldn't worry so much about the LDL is at the beginning, and let's just treat anyone based upon what their risk. Again, if their risk is high, we can lower it by a quarter of a third. That has value. Let's do it. And again, if they're young and their risk is low, it doesn't matter so much because we're making a small number smaller. Right now in our practice, we do both of those things. We do look at overall risk, but we still look at the LDL because the higher it is, the more we want to lower it. But we keep in mind the fact that even if your LDL is relatively low, lowering it further may have benefit. Now, I'm going to start by showing the guidelines from the American College of Cardiology and the American Heart Association. And I'm going to call these the cardiology guidelines. I'll show you some other guidelines as we go through this. But these guidelines pretty much dominate clinical practice. And rather than showing so much competing guidelines, what I'm going to do is show you the strengths and weaknesses of these guidelines. But for the most part, these guidelines drive most of our clinical practice. However, I think you'll see as we go through this that there's a lot of nuance. And that is to say, there's a lot of room for shared decision-making, or putting it another way, for your personal values and desires to become part of the conversation. So these guidelines are well done. They're based on clinical trials. They also look at some other lines of evidence, but mostly the big clinical trials like the ones I just showed you. They recommend a healthy lifestyle for everyone, no matter what your cholesterol is, and I'll define that in a minute. They talk about 4 groups of patients who benefit from statins, and I'll define those also in a minute. They describe different types of statins, what we call high-intensity statins, moderate intensity statins, and lower intensity statins. They focus on the LDL as the treatment target, but again, they also focus on your risk by using an equation that calculates your 10-year risk of atherosclerotic cardiovascular disease. That's what the ASCVD means. It means a combination of heart disease and stroke. And then they define non-statin therapies for some patients, and we'll review at the end what those are, what options those are. But mostly what we're talking about here in these guidelines is the use of statins, primarily because they've been around for a while. They're well priced. They lower cholesterol a lot, up by the 30 to 50%, and they lower your risk of a heart attack or stroke by a quarter or a third. And so the statins are the mainstay. Despite what you'll might read on the internet, the statins are the mainstay of high blood cholesterol treatment. And it's why we have lowered that risk of coronary artery disease and stroke so effectively over the last 40 years. Now, here are the 4 groups of patients. Some of these are not controversial, and some of them have more nuance. The first 3 are relatively non-controversial. Now, number 1 is the top one, and a patient who has already had an event or some evidence of heart disease or stroke, whether that's exertional chest pain that we call angina, a prior heart attack, whether it was a serious one or a minor one, a transient ischemic attack, or some people call it pre-stroke, or a minor stroke, or a bigger stroke. All of these people already have the clinical disease that we're trying to prevent. And we put them in a different category, what we call secondary prevention. So if you've had the disease, either heart attack or stroke, or any of the preconditions, then we recommend that we lower your blood cholesterol aggressively for most of the rest of your life, until really the very end of life when you're beginning to terminate other interventions. So patients who have had a stroke or a heart attack stay on statins for the rest of their lives. When you go into the hospital, the neurologist or the cardiologist will start you on a very high dose of statins the minute you come in. And you'll be on the highest dose of a high intensity statin. And I'll define that for you in just a moment. But there, in this context, there's no controversy. Treating with the statins helps in the hospital, and it also helps prevent recurrent events after the hospital. The second button, excuse me, is less common and less controversial. These are people with primarily genetic disorders. And so these are people whose LDL cholesterol is very, very high. Remember in the earlier slides, we were talking about 130, being over 130, being over 100, being under 100. Here, these are people whose LDL cholesterol is over 190. These are almost always genetic disorders. And this can be sorted out mostly by family history. So many of you may remember when the statins first came out, there were some of the commercials that were very effective, talked about, is your high cholesterol from your grandmother or your diet? And it turns out it's mostly from your grandmother. That is to say, genetic factors are the primary drivers of your own blood cholesterol. And so if your first degree relatives, that is your parents or your siblings or your children, have very high LDL cholesterol, you may well as well. Your risk of it is much higher, and that's primarily genetic. And those individuals typically, if you don't even know the cholesterol, depending on what era your parents are from, you may know that they died prematurely of heart disease or stroke. And so the risk factor that we think about clinically is premature heart disease or stroke, less than age 55 in a man or 65 in a woman. And we call that premature disease, but it's first degree relatives. If your Uncle Joey had a heart attack at 72, that doesn't confer any extra risk to you. What we're looking for is premature, that is young age, heart disease or stroke. And when we evaluate those patients, those are the ones who typically have LDLs that are over 190. These days, the third bullet are patients with diabetes. And we pretty much treat the patients with diabetes similar to the way we treat the patients who have already had a heart attack or stroke. That is to say, we treat them. There's a little bit of nuance here. We say 40 to 75 only because that's when the studies were done. We don't believe in treating children with diabetes with a statin, but adults with diabetes, most of which are type 2 diabetes, who do have premature heart disease and strokes, treating them with a statin is part of their standard of care. Again, you can extend this past age 75, just like up here, there's no age limit because we consider patients well into their 80s and 90s if they've had the disease. Here, it just says 75 because the studies didn't go after 75, but most clinicians would continue to treat a patient with diabetes, again, well into towards the end of their life with a statin, as well as their diabetes medications. Now, the fourth bullet is where we have most of our conversation, where most of the nuance is. And these are individuals who do not have heart disease or stroke, do not have atherosclerotic cardiovascular disease. They do not have diabetes. They're middle-aged, and again, simply because that's where the studies were done. It doesn't mean you can't continue after age 75, but we do so with less evidence. They have an LDL that's not perfect, that is over 70. And again, we use an equation and estimate their 10-year risk. Now, this number 7.5% is where there's a lot of controversy, and I'll come back to that. But this is what the cardiology guidelines recommend. And this is linear, so if your 10-year risk is 7.5%, it means your 1-year risk is 0.75%, so 1/10 of that. but to think in terms of 10 years rounds up the numbers. And this number 7.5 is something we'll come back to because that's where the controversy is. So in summary, there are 4 groups of patients who benefit from statins. Most of them are straightforward. If you've had the disease in any format, we treat. If you have a genetic disorder with a family history of premature heart disease or stroke, we treat. If you have clinical diabetes, we treat. And then in this 4th group, if you have risk of having heart disease or stroke based upon other factors, whether that be your age, your sex at birth, your body mass index or weight, your exercise level, your smoking history, and so on, those things all go into our equations. And if the risk turns out to be above a certain number, then we would recommend treating you as well. And this last bullet we'll spend some time on. So we're going to focus most of the time tonight on the medications, statins and others. But it's worth keeping in mind that the lifestyle recommendations remain secure and should be part of every conversation related to preventing heart disease and stroke. And that's true whether your cholesterol is normal or not, because there's benefit from these lifestyle recommendations independent of your cholesterol. And that is a heart healthy diet, which I'll define in the next slide, regular aerobic exercise, which I'll also define more in the next slide, maintaining a desirable body weight, which we'll talk about next week, and not smoking. And so these are the 4 pillars, if you will, of lifestyle recommendations to prevent heart disease and stroke. Now, the heart healthy diet, there's not too much new here. You've learned these principles for several decades now. And it's interesting when you read the nutrition literature and hear about a new diet it goes to one extreme or another. Almost all the diets have these things in common. That is, it should include lots of fresh fruits and vegetables, nuts and whole grains, lean vegetable and animal protein, and fish. Now, you can do this without the animal protein and fish. That is to say, vegan diets and vegetarian diets are perfectly healthy in this context. You can do it without as much grains if you're on a lower carbohydrate diet. But the most important thing is to eliminate the things that we want to avoid in our diet. Trans fats are pretty much out of the US food supply. It's taken a while, but they're mostly gone. They were mostly in highly processed foods and fast foods, but they've been mostly eliminated. But the 2 things that raise your blood cholesterol, your LDL cholesterol, in the diet are primarily saturated fat and total calories. And so red meat has more saturated fat in it than chicken or fish or vegetarian proteins. Processed red meats like cold cuts and so on fall into the same category. And then, of course, in any good dietary advice these days, we want to avoid refined carbohydrates. That is white breads and white pastas, pizza, and so on. Some of the foods I showed when we talked about salt in the diet, same foods. And of course, to avoid anything with added sugar. So sweetened beverage are first on the list, but there are many, many, many other things that have added sugar. And so that becomes the highlight. So if you're focusing on things to avoid, you focus on avoiding added sugar, avoiding refined carbohydrates, or eating them modestly, and avoiding lots and lots of saturated fat, which comes mostly from red meat and whole dairy products. Conversely, if you want to focus on what you should eat, it's mostly plants, so fruits and vegetables, nuts, whole grains, and then either vegetarian or non-vegetarian with adequate protein from either vegetables or chicken and fish. And again, we recommend maintaining a good body weight, and we'll focus on that next week. Now, regular aerobic exercise has been a recommendation that's been resilient. That is to say, it was made decades ago, and the studies continue to reinforce the importance of this. And there's a lot of evidence, and we'll talk about this again in the context of weight. But no matter what your body weight is, even if it's normal weight, or if it's in the overweight category, or in the more severely elevated category that we call obesity, if you are fit, which means if you exercise per these recommendations, you obtain benefit on cardiovascular events and diabetes and life expectancy, independent of your body weight, if you are able to achieve fitness. And what I mean by fitness, there are many ways to define it, but this is one way to define it, which is 150 minutes per week of moderate intensity physical activity. So that means going for a walk most days, typically about 30 minutes or so, 5 or 6 days a week. I like to joke and say that exercise is biblical, 6 days of exercise and 1 day of rest. And you don't want to do it 150 minutes all at once. You want to spread this out through the week. So I recommend 6 days a week of moderate intensity cardiovascular aerobic exercise. Now, if you are a jogger or other sports with more vigorous exercise, you can achieve the same goals with less. But as patients get older, we mostly focus on moderate intensity exercise. Now, there was some interesting studies just this month that not only reinforced this, but also began to suggest that maybe more than 150 is the magic number. So getting up closer to 200 or even 300 minutes per week gets into the highest amount of prevention from aerobic exercise. And so that in many of the studies, it's up to an hour a day, 6 days a week. And that's where you get up into 300 or more minutes per week. So that's a lot, and we don't recommend that anyone start that immediately. We don't want people to do it intensively. We want you to do whatever you normally do, just do more of it. I care more about frequency and duration than I do about intensity for most patients. But this is the single most important thing you can do for your overall cardiovascular health, independent of your body weight and independent of your blood cholesterol. Now, it's worth noting that when we talk about exercise, and this is not a talk just on exercise, but when we talk about exercise, so far I've talked mostly about cardiovascular exercise or aerobic exercise that gets your heart rate going up and sweating a bit. An activity at which you can talk but not sing is another phrase that people use to describe this. But remember that fitness also includes strength, flexibility, and balance. And especially as you get older, those three other factors become extremely important as well. All right, so we've talked about 4 groups who have heart disease, who have indications for statins. And let's think now about what we specifically recommend as treatment for each of these groups. So if you have the disease, so you already have clinical atherosclerotic cardiovascular disease, you already got a high intensity statin when your event happened in the CCU or the neurointensive care unit, and you're discharged home on the high intensity statin, you should stay on it. And so the goal, if you have the disease, is to take as a high dose of statin as you can, and I'll define what those are in just a moment. The high intensity statins lower your LDL cholesterol by 50%. So it's really quite dramatic. So if your LDL was 160, when you had your stroke or heart attack, the cholesterol, the medication can lower it to 80. So it's really quite remarkable. In some patients who are at very high risk, the guidelines talk about adding other medicines if the LDL does not drop below 70. That's a little controversial. That's more of the nuance, and I'll come back to that in a moment. But the most important thing to do is make sure you're taking the highest dose of statins that you can tolerate within the limits for each medication, following that it lowered your LDL by about 50%, and that's giving you the maximum benefit. For the genetic disorders, we do the same thing. we treat with a high-intensity statin. And again, we can use some other of the newer drugs if we need to, but often because the statins are so potent that even if you start with an LDL of 190, we can often get it down to under 100 with just a single medication. But certainly some patients with bad genetic disorders and very striking family histories may consider other medications, but they're not as effective as I'll show you in a minute. Patients with diabetes, it's similar. We either use what we call a moderate intensity statin or a high intensity statin. Most patients, we try to get up to a high intensity statin if we can. And so far it's pretty simple. For the top three groups, whether you have the disease, whether you have diabetes or whether you have a genetic disorder, we try to get you on the highest dose of the statin that we can. And the tricky group are the patients, what we call primary prevention. That is patients who don't have atherosclerotic disease yet, and hopefully don't want to get it, don't have diabetes. Again, the age is a little arbitrary because that's being scientific. That's the age at which the studies were done, but we can stretch those ages if we need to. If the LDL is above our goal, and you have a risk that we can define in 10 years that's over some number, at least 7.5%, then what we recommend is begin that process of what we call shared decision-making, where you and your clinician discuss whether you should start a statin as primary prevention. And this is similar to the kind of conversation you would have for treatment of high blood pressure. Now, there are various ways to have this discussion that we call shared decision-making, and I'll illustrate this in a number of different ways. And a lot of it has to do with what your own values are and what your own risk is and how risk averse you are. But there may be other factors that are important to you that we call, that may be other risk factors, say cigarette use or weight issues, or you can't exercise. But in addition, there are things that we call risk enhancing factors that I'll define in the next slide that also increase your risk a little bit further than what our equations show. And I'll define that more in just a moment. But again, a lot of this comes down to your preferences and values. Now, this is a long list, and different clinicians will, this is from the cardiology guidelines, and each physician will look at this list with nuance. That is to say, if you're a rheumatologist or caring for patients with HIV or bad skin diseases, you may look at it from that point of view. If you're someone who really pays attention to family history, that may be one of the most important parts of your decision making. So if I have a patient who's younger, but they say my dad died at 48 and I'm only 40, but I'm nervous, that becomes a very important part of the conversation. If the LDL is very high, like we talked about before, metabolic syndrome is pre-diabetes or other abnormalities, chronic kidney disease, issues of obstetric issues, particularly preeclampsia, chronic inflammatory disorders, in this case, some of the rheumatologic diseases. RA stands for rheumatoid arthritis. Some high-risk ethnic groups. There's some very important research over the last decade or so from UCSF and elsewhere suggesting that certain South Asian populations have higher risk even at the same levels. If the triglycerides are very high, again, different clinicians interpret that differently. Some clinicians will look at other factors in the blood. And there are new scans that you can do which may also reflect how much early atherosclerosis you have on your coronary arteries. All of these, if they're positive, increase your risk, and they're not part of our equations. So if your equation is 10% and you're sort of in a borderline zone, then using one of these other factors either by history or by additional testing, may be something that you and your clinician want to do. The most important point to me, though, of this, other than the things like family history, where sometimes that really drives the conversation, most of these other things, like if you test a C-reactive protein and that's really high, or your coronary artery calcium score is high, or so on, most of these other factors increase your risk by about 20 or 30%. So what I mean by that is if your risk over 10 years is 10% and you have some of these, it may go to 12%. And that's important to keep in mind. It doesn't go from 10% to 30%. That would be a 300% increase. It goes up by 20% or 30%. And sometimes people think, well, I have a coronary artery that's positive, I should definitely take my statin. Not necessarily, because it increases your risk, but if your risk started really low, that maybe it still keeps you in a relatively low place. And again, lowering a small number doesn't confer much benefit. So this is where the nuance is. This is where there's differences amongst clinicians and maybe to a certain extent amongst special types of different specialties. But it's important to know about this. They all are relevant, but they are not all required. In fact, none of these are required most of the time, with the exception of family history, which we do regret is not in our equation. That's the one thing we want to consider in everyone. But whether to add some of these other factors is between you and your clinician. That may help you make your decision. Now, I've mentioned the statins a lot, and these are the high-intensity statins and the moderate-intensity statins. And as you remember from our guidelines, everyone either got a moderate-intensity statin or a high-intensity statin. So this turns out to be pretty easy because there are two medicines, both of which are now generic, both of which have been around for quite some time, that are in both groups. That is atorvastatin and rosuvastatin at different doses qualify as a moderate intensity statin and lowers your LDL by 30 to 50%, or a high intensity statin and lowers your LDL by 50%. And so many clinicians use one of these two drugs, mostly because it's you can get in the ICU, as I mentioned, and the CCU, where people get started on a very high intensity right away. It's easy just to prescribe one of these at the highest dose and discharge the patient on that. Similarly, in the clinic, we often follow principles of starting low and going slow. So we might start again with one of these two medicines at a lower dose, and then see how the patient's doing with it, and just make sure that we don't have what we call clinical inertia. If your goal is to get to, say, a high intensity statin and you start atorvastatin 10 or 20, you don't want to get stuck because you forgot. And so we start with 10 or 20 sometimes to prevent side effects or just make sure the patient feels comfortable. But the key is to get it up into the zone we care about if we're trying to use a high intensity statin. So rosuvastatin, which is used to be, when it was trade name, was Crestor, and atorvastatin, which is Lipitor, are the two most commonly used statins in the United States. Atorvastatin became generic before rosuvastatin, and so many doctors, because it was cheaper, just got in the habit of using atorvastatin. So that's by far the most common. There's nothing wrong with the other statins. Simvastatin, pravastatin, lovastatin are fine. They just can't get into the high intensity range. But if you're on simvastatin or pravastatin or lovastatin, and you and your clinician's goal is to keep you on a moderate intensity statin, and you've achieved your therapeutic goal of getting your LDL less than 100 or less than 70, with those drugs, there's no need to switch. So I have many patients who started on simvastatin or pravastatin are still on them, and that's fine. Sometimes as they get older, or if they have a new indication for more intensive therapy, we might switch, but it's not required to switch in everyone. It's just simply convenient that rosuvastatin and atorvastatin are in both categories. So it's a convenience with those two medications, but the other three are also fine as long as your goal is moderate intensity statin. Now, I've talked about equations, and these are widely available. I'll show you some websites where you can look at these. They're in the medical record. Your doctor can pull this up for you with a very quick click in the office. And there's a standardized equation that we use in the United States. But it turns out that there are hundreds of these equations. It's pretty easy if with what we call a regression analysis or advanced statistics to look at a whole bunch of risk factors in a given study and come up with an equation. But this one, which is called the pooled cohorts equation, is generally accepted as the one that we use in the United States. And like I said, it's built into the medical records that most people use, the EPIC system and others. So these are, and you can get an app, put this on your phone, but again, you only need to calculate it occasionally. So you can go to a website also, and I'll show you the URL in just a moment. But it's interesting to think about what are the building blocks of the equation. And that is, it's your age, your sex at birth, your race, and here it's categorized by white, African American, or other. I'll come back to that. Your total cholesterol as a factor of the overall equations, the HDL cholesterol, the systolic blood pressure, whether you're on medications for blood pressure, whether you have diabetes, and whether you smoke. So those are the factors that the equation uses, and these again can be obtained right off your medical record or from an app or the website. So it's very easy to do this, and what you get with this equation, and again I'll show you an example, is the 10-year risk of total cardiovascular disease, both stroke risk and heart attack risk, over 10 years. We used to use an older equation called the Framingham Heart equation from the old Framingham Heart study of the 1950s and 60s. And that didn't include stroke. So this new equation includes stroke. So everyone's risk went up over time because stroke risk was now included. And that is particularly important for women for whom heart disease comes later in life, and stroke is almost as common as heart attacks at many stages of life. So stroke is, in men, a heart attack is greater than stroke risk in most ages, but in women, they are closer together. So this newer equation that includes stroke risk is very important. Now, the problem with this equation, which is widely used and not really thought too much about, is that it's very, very imperfect. And I'll show you several slides that illustrate the imperfections. Now, having said that, I use this equation every day. It's the one, like I said, that's built into our systems, and we do use it, but one should interpret the results with some nuance. The first issue is race, and we know from our increasing understanding of systemic racism, that the use of race in these equations may be very flawed based on how the equations were done, how the studies were done, who was included in the studies on which the equations are based, how people were categorized, and so on. And so for many of our other equations, we have eliminated race. So in kidney disease equations now, we've eliminated race, and we have several ways to get at that. This has not yet been accomplished for heart disease, although many scientists are working on that as best they can, is to try to find risk prediction models that are not based on this older concept of race. So that's one flaw right at the get-go. What do you do about that? Well, what we used to do in kidney disease before we had a new equation it was sort of a workaround. But what you can do when you fill out the equation is you can fill it out with all three categories. So fill it out as white, fill it out as black, and fill it out as other, and you will get a range of risk for you, based on your other risk factors and your age and sex. So just like with kidney disease, you might see a low estimate and a high estimate, and know that you're in between those most likely. That's one way to do it. It's not an official recommendation. It's totally a workaround because we have a flawed equation, but it is something that's available because our apps and websites do give us three options based on race ethnicity. Again, I'll show you what a better equation might look like in a minute. Now, another problem with this equation is something that's been known for quite some time. So this is three studies. It makes for a complicated slide. But let's just say, for example, look on the left-hand side of the slide. This is one study. And so what they did when they made this equation, as they would for any risk equation, is looked at a particular group of people, did the equation, and then tested the equation accuracy in predicting risk in a different group of people. And what they showed is, and the gray lines here showed what the risk was of having heart disease or stroke based on the equation, what the predicted rate would be over 10 years. And then when they tested it in other studies, and Northern California Kaiser did one of these studies, you can see that it was substantially less. So the equation said your risk might be 20%, but in fact it was closer to 10%. And that's true throughout the values. And it was true, and it's been true in most of the studies that have looked at this. So the equations probably overestimate risk pretty consistently. So when someone says your risk is 7.5% or 10% based on the equation, your actual risk may be less than that. And if your risk is less than that, then again, from that first slide, if your number is low, if your risk is low, lowering it may not be worth it. So there's another flaw of our equation. Now, this is a website that I like called the Mayo Clinic Statin Choice Decision Aid. You don't need the URL, just Google Mayo Statin or Mayo Decision Aid. Comes up right away. And what's nice about this equation are several things. One of them is there, as I mentioned, although the equation, the pooled equation is the one that's sort of won the game, that's built into our medical records and used commonly in clinical decision making. There are others. And much like we talked about in terms of race ethnicity, you can look at some of these other equations to frame your risk using different tools. And so the statin choice, the statin decision aid website lets you use the old Framingham equation, this new equation, and another equation called the Reynolds equation, which includes your C-reactive protein and family history as well. So there are other equations out there. And again, on this website, you can look at all three rather than the one that's built into your doctor's medical record. The other thing that's great about this website is it can translate the numbers into pictures, a pictograph like this. And so let me spend a minute on this to try to illustrate the point. So I've been talking about risk as a number, risk of an event in 10 years or risk per year. And the higher your risk, the more important it is to treat you. If you have the disease, that's high risk, treat. If you have a genetic disorder, high risk, treat. But if you don't have anything and you're young and low risk, maybe don't treat. There's also something in medicine that we call the number needed to treat, which is how many people like me need to get the medicine I'm about to take before I benefit. And here's what that looks like. And so let's imagine in this example that there are 100 people like you who are not on, no one's on any medicine, and we do the equation. And it turns out your risk is 11% in the 10-year model. So 1.1% per year or 11% over 10 years. What that means, in simple arithmetic, if you have 100 people like that, no one's on a medicine now, you can see that we have 11 orange frowny faces. So this is meant to be a frown, and your frowny face suggests that these are the people out of 100, because the risk is 11% out of 10 years, that 11 people out of 100 will have a heart attack or a stroke, in this case, a heart attack, in the next 10 years. What that means is that 89 people won't, right? So these green smiley faces are all people who, even though they have the same risk, their risk is also 11%, they're not going to have it, right? They won the lottery, they didn't get it, even though their risk was just as high. Now let's say we move to the other side and we put you on a medication. And if we use a medication like moderate intensity statin, then I've already told you that that lowers your risk by a quarter or a third. So let's say, for the sake of discussion, that instead of it being 11 people, because I lowered it with the statin, now there are only 8 frowny faces, right? Because only 8 people will have a heart attack. There are 3 people here who won the game, right? They're the 3 people who, by taking a statin, didn't have a heart attack. We lowered the risk by a quarter or a third, right? So they have a big blue smile. But look at the green dots. So the green faces are still the same 89 people. So this is where it gets a very nuanced. So 89 people didn't have a heart attack here without medicine. 89 people didn't have a heart attack here, but they had to take the medicine. So, and then 8 other people, even though they took the medicine, because it wasn't a perfect medicine, still had a heart attack, and 3 people benefited in this example. So this is a very subtle and nuanced process. This is what shared decision-making is one of the tools of shared decision-making, is trying to convert numbers and risks and percents into people. Now, the challenge we have as a community, as a profession, and as a population is that for you sitting across the table making this decision, you realize that you have to treat a lot of people, treat 100 people to prevent 3 heart attacks. And you have to take the chance of being one of those people. So for you, the number needed to treat is relatively high. You have to treat, say, 89 people, treat 100 people to prevent 3, so it's 33. But from a population standpoint, we're preventing 3 out of 100, and that's a lot of lives, a lot of heart attacks. So this is where it gets very confusing, because if you're thinking about the whole population, then maybe statins should be in the water supply, and we should just lower everyone by a quarter or a third. But since we don't practice medicine that way, we give people individual choices, and you have to think about what's your personal value. Do you want to take the risk, or do you want to hedge your bets by taking the medication? But clearly, from a population standpoint, treating aggressively will prevent heart attacks and strokes in the population. But for you, you have to make a decision. And you can see why, in this example, the risk was 11%. You can see where if I made this 15%, it doesn't really change the conversation that much, right? So whether it's 7.5 or 11 or 13, it doesn't really matter that much. By the time you get up to 20, that's the point at which that's the same risk as if you've already had a heart attack, a risk of having another one. So 20% risk is a high number, and everyone agrees on that one. I think between 5 and 20, that's where there's nuance and debate. Now, this is a slide I saw presented on a similar topic. As I mentioned, it's very easy to develop risk equations, and the literature has literally hundreds of them. It's a very easy thing for a statistician to do, and many statistics graduate students have done them. So there's a full of literature on this. But this is what the United Kingdom is using as part of their federal health system. And so instead of the one that we're using that's available on your app or on the website or on your doctor's chart, they use a different calculator based upon their own assessment. And it's interesting to look at it. And I put it, this is on 2 different slides to really emphasize the difference. They have a wider age range. They still look at sex. And remember, we used Black, we used Caucasian, Black, and other, but they break down your ethnicity with great nuance, focusing more on ancestry rather than, quote, race. And they make some subtle distinctions because there, as I mentioned, there are differences between South Asians, for example, and East Asians. Where you live, so your neighborhood determines the social determinants of your health, your access to food, your income level, your education level. And the postcode is meant to be a surrogate for some of the other social determinants of health that are not factored in. Whether you smoke, whether you have diabetes, those are the same. Whether you're on blood pressure treatment, that's the same. And then they also factor in some of these other illnesses, that some of which were on our list of enhancing factors, but not all of them. But things that also have been shown to increase your risk, the rheumatologic diseases that we talked about, but also some medications that also may increase your risk. Your lipid numbers, as we do in our equations, your blood pressure, the variation of your blood pressure, which is a subtle factor, and your body weight, which we do not include in our equation. So this is the one that they use. Here's the website here. These slides will be on our website, so you can get this later. You don't have to take a photo of it, but please do if you want. And in addition, but this gives you some insight into other ways to calculate risk. And so it's looking for more nuance. All right, so in summary, the last many paragraphs were really to make the point that we make a lot of decision-making based on risk assessment, which we do primarily in the United States with the standard equation, keeping in mind that there are other equations and that the equation we use overestimates risk and may have other flaws, and that there are other factors which modify the risk by 20% or more that may help you make your decision. And then finally, when making a decision, you have to decide your own values, your own risk averse, how risk averse you are, how much risk you're willing to take, whether you want to maximize the decreasing of your risk of a heart attack or stroke, or whether you think, well, the odds don't sound so bad, I'll take my chances. On the other hand, your decision is in contradistinction to what's best for the community at large, because if we all took the medicine and lowered things by the risk by a quarter or a third, the rate in the society would continue to go down. All right, let's end by talking about a few other medications briefly. These are less important, and I'll go over them quickly, but some of them are of historical interest and some of them are new. But just to reiterate, statins are the treatment of choice based upon randomized trials. That's what we've talked about. We used to use niacin or fibric acid derivatives, fenofibrate and others, to either without statins or added to statins. And we now know from convincing scientific studies that if you're on a statin, taking extra niacin or extra fibrate does not increase your benefit. No extra reduction in risk. And in fact, one of the studies showed that if you took niacin at therapeutic doses, you did worse. So niacin and the fibric acid derivatives should not be used with statins. Occasionally, we use them alone, particularly in people who can't tolerate statins or who have have particular distinctive lipid patterns. But this is increasingly uncommon because there are other drugs that are more potent. But you may still see some occasional patients on fibric acid derivatives. Fenofibrate is a common one. Clofibrate is an older one. but these have niacin and fibric acid derivatives have fallen out of favor. The newer drugs include ezetimibe. This is a drug that does lower your risk, but not very much. And instead of a quarter or a third, it lowers your risk of events by 6%. And this was in a study that took 7 years. It was a study that was funded by the drug company. It was planned as a 5-year study. It was a totally negative study. 6 years, totally negative study. Finally, at 7 years, they showed the small benefit that achieved statistical significance. And so personally, I rarely use this drug, but I can't say it doesn't work. It just doesn't work very much. So it has a very marginal extra benefit on top of statins. Remember, statins are a quarter or a third, and this is 6%. So this is a drug that some patients, especially who have already had a heart attack or stroke, may take if the statins have not lowered their cholesterol enough. There are two newer drugs that are common, the PCSK9 inhibitors. They inhibit a protein in the liver that changes how your liver degrades LDL. They're very effective. They're monoclonal antibodies. They have to be given by injections. They're expensive, but they lower your LDL cholesterol a lot, by 50% over and above what the statins have done. So these are very effective medicines in lowering your cholesterol, but they do require injections either every other week or once a month. And they are approved in the United States for genetic disorders and also for other patients who need additional LDL lowering. The problem with these drugs is that despite the fact that they lower the cholesterol by another 50%, which is a ton, so you can get the LDL down to, rather than less than 70, it might be 30 or something in that order of magnitude. What it did was that it lowered heart disease and strokes to a certain extent, by about 15% or so, and 20% in one study. So not as much as statins. And you needed to treat a lot of people in order to get that benefit. But the most troubling thing is that there was no reduction in mortality. So as opposed to statins, which prevent heart attacks and strokes, but also prevent death from heart attacks and strokes, this medicine did not have that benefit. Nonetheless, it does reduce the event risk more than ezetimibe, less than statins. But it's been disappointing. I think we thought at the outset that if we lowered the cholesterol that much more, we would have a much more dramatic impact, and that's not what's been seen. So these drugs are available. They're mostly used by cardiologists rather than primary care clinicians. They are still expensive, although the prices come down with time, and they are available for selected patients. But these are not in common usage. There are some, and then what the Cardiology Society says that these drugs may be considered. We don't really know yet too much about the long-term safety because the studies were 3 years long and they are expensive. So the economic value equation is poor. There are some other drugs that are in the pipeline. They also are much less effective than statins and more in the ezetimibe or PCSK9 category. A little bit of benefit, whether they come to utilization or not, time will tell. But the science continues, but nothing has really matched statins. So to get back to our patient, remember the question was, what should we do next? And again, the theme of this has been shared decision-making. And in fact, that's what we should do, is begin the process of shared decision-making, trying to balance those benefits and risks. In the office, if we were going to start a statin, we typically would start probably atorvastatin or maybe rosuvastatin, if it's covered by insurance, at a low dose, and then build up slowly to a moderate or high intensity. We don't use aspirin anymore because the risk of bleeding turns out to be as much as the benefit, but this is primary prevention. If you've already had a stroke or a heart attack, you should stay on your aspirin. And then fish oil has not been shown to prevent heart attacks or strokes, despite some old studies that suggested that it might. So we don't recommend fish oil. The good news is that fish oil, though, is benign. So if you're taking fish oil, no harm, no foul. It's not dangerous like some other supplements can be, but it doesn't work much either, except in the one case where if your triglycerides are very high, fish oil can be used in a different way to lower your blood triglycerides. And there's a new form of fish oil that's now available for that purpose as well. So to conclude, statins are effective and cost-effective in 4 groups of patients. The 3 easy ones are those who have atherosclerotic cardiovascular disease, diabetes, or genetic disorder. And then after that, it's more nuanced. It's the primary prevention conversation. And if you're very high risk, no one has any argument with it. If you're over, say, 20%, some people would say 15%, then by all means, it's an easy discussion. I think where there's debate is whether your risk is in that 5 to 15% risk. Most cardiologists will say 7.5%, some will use 5%. The U.S. Preventive Services Task Force, which is a more a group of specialists and generalists, but mostly generalists and epidemiologists, recommends a more conservative 10%. And again, I think what's most important is you can use other factors to see if that 10 goes up to 13 or 14 or goes down to 6. That may help you for your own risk with some of the risk enhancing things that we mentioned. And again, that may help you in here as you move between 7.5 and say 15 or 20%. And then in certain patients, again, mostly under the care of a cardiologist, you could add a second medicine, but almost always in conjunction with a statin as well. So with that, I will stop and see what we have in the way of questions. How does the mechanism of statins? They change the metabolism of degradation of the statin. So that it is known what the mechanism is. It's well established, and it interferes with the body's enzymes, which metabolize blood cholesterol. Thank you. The risk of diabetes for taking statins is an important question. I should have mentioned that. There is a slight increased risk of your blood sugar going up while you take statins, and diabetes is defined as having a blood pressure above a certain number. In the United States, we use 126. And so if you happen to be close and the statins raise your blood sugar a little bit and you just cross that line, then technically you may throw some people into having true diabetes rather than pre-diabetes. The actual risk of that difference is subtle because the relationship between diabetes and health is a gradual line that builds, just like your blood pressure and your cholesterol. So although we think of normal pre-diabetes and diabetes as very hard and fast categories, it turns out there's more subtlety there. And the studies that I showed you that showed that statins lower your risk of a heart attack or stroke by a quarter or a third took into account the impact that it had on your diabetes risk. So it is true, your blood sugar may go up a tiny bit in some cases. I rarely see that, but it's in the literature. And the occasional person in a big group might cross over into diabetes, but that's a subtle difference compared to the overall benefit of the statins on preventing heart attacks and strokes and preventing mortality. Does drinking alcohol affect cholesterol levels? Not too much. It affects your total cholesterol because it can increase your blood triglycerides. So when people have a high blood triglyceride, we're always looking for reasons, and alcohol is one of them. Estrogens can raise your triglycerides, certain kidney diseases, but the most common is an elevated blood sugar. So patients with diabetes or prediabetes often have elevated blood triglycerides, which may not be all that important unless it gets very high, but it may increase your total cholesterol based on that equation I mentioned at the very beginning. So yes, it can affect your total cholesterol, but it does not affect your LDL cholesterol. There's been some talk over the years that maybe moderate alcohol use would, which has been shown to be associated with longer life expectancy on average in populations, compared to both heavy alcohol use and being a teetotaler. But those are mostly observational studies that could be confounded. But there's been some theory over the years that maybe wine or red wine or some other alcohols can raise your HDL or good cholesterol, but the science around that is not very secure. So in general, if you prefer to be a teetotaler, we support that. If you prefer to drink alcohol moderately, we support that. And we try to avoid substance use disorders of people who are high-risk drinkers and consume too much. Does climate rather than nationality or ancestry have an influence on your risk? Is global warming going to be a problem? Do populations in the north do better or worse than populations in warmer climates? You know, I think that's a mixed bag. In general, it's been the developed countries of the north that have had the highest risk of heart disease and strokes. And that's not, it's not known whether that's environmental or ancestral or environmental. However, as I suggested, there are some warmer climate populations, some of which are quite large, like Southern Asia, that have higher risks for equal body mass index, equal weight, equal cholesterol levels. So we don't know the answer to this question. Global warming is a big problem any way you cut it. I guess in the context of what I've talked about tonight, eating lower on the food chain is probably the most relevant thing that we can do. And of the things that I mentioned, in terms of eating less red meat, because of the amount of energy that's consumed in producing red meat. So that's another argument for eating less red meat in the context that we've talked about. And the last question, what is the range of time it takes to modify one's numbers with lifestyle changes? Is lability of blood pressure a risk factor? Good. You know, generally we give people several months of lifestyle before we see them in follow-up. It depends what the goal is. If it's weight loss, for example, we may see someone more intensively depending on their motivation and wishes. But generally it takes several months to begin to see the effects of lifestyle changes. But remember, I wasn't as clear as I might have been on this. Diet, remember the joke about your grandmother or diet. Most of your cholesterol is driven by ancestry and genetics. The best studies of the best diets that we use along the lines of what I mentioned, lower your LDL cholesterol by about 5%, 5, maybe 10%. So it's very, very hard with, and statins lower it by 30 to 50%. So diet, the benefits from lifestyle are very, very important, but you won't see it necessarily on your LDL cholesterol. It's a benefit you get beyond the cholesterol. And so for better or for worse, statins are much more potent than diet, even if you restrict saturated fat severely and total calories severely. LDL is often hard to move. Now, there are some studies in the literature that can get LDL down 15 or 20%, but they're very unusual diets, eccentric diets with lots of foods that are been shown to lower cholesterol, like soy products, very high fiber diets, and certain nut products and the like, but they're not really palatable diets. When we talk about the heart healthy diet that we mostly talk about, the benefit on LDL is about 5%. If you lose 20 pounds, it might be more than that if you're overweight. But again, your blood pressure and your blood sugar come down much more effectively with exercise and diet than does the LDL cholesterol.